was this issue about the airway and respiratory management. I don't see anybody I don't see anybody particularly that was supposed to be doing some of that aspect of things that I'd asked on that who were going to be there. So, okay. All righty. I see Rick Martinez is on. It's good to hear from you, Rick. So it'd be interesting to hear some of your perspectives as we get on. And is Kevin iPhone X, is that Kevin McVaney? iPhone 10? Kevin?
Yes,
is that
sorry. Sorry,
yeah.
I went in through the Zoom thing, so I didn't realize it was just going as my number. Yeah, so I'm
no,
on.
That's fine. I just like to know who it is, and I still need to know who 678 is. So that's it. All right, I'm gonna go ahead and just start moving along. We're gonna have a pretty, I think, easier agenda than usual because I was trying to transition us. A couple things I want to say. So, Craig, do you want to do the usual start off so we can start recording this and tell them all the usual caveats?
Yeah, we're already recording, but as most of you know, but for our guests who are on board, this is a live recorded session, so we do record it, and then it is published on the useagles.org website as well as on EMS World for other EMS medical directors and other EMS professionals to observe and hear our deliberations. And so with that, we just always ask you to be aware of that. With your comments and deliberations that we have, just be aware that they are in a public domain and searchable process. And so with that, Paul, it's your show.
And once more, thanking District 7 for putting this on and providing their personnel and resources to make this happen. Okay, so it looks like, by the way, I just want to tell everybody, it looks like the Eagles website is evolving nicely. I'm just going to start with a meeting with Stein Bronski the next couple of days, sort of to tune it up a little bit more, get it up to date, because we're creating it and developing it from what we had before. I think it's going to be have a lot of good information in there, and but we still need some people's photos and pictures, and I may have some of those for you that I already possess, Stein, as we get on to that. Okay, I was going to have Mike Osterholm come on, and he is tied up now with a meeting because he has to have something he has to do with the Federal Reserve of all things next week, and so they're preparing for that. But he is going to try to pop in later on. I just wanted to bring up, though, that he had another publication this week, this time on testing. It's kind of a, so again, if you just go to CIDRAP, which many of you may remember is CIDRAP, just go to CIDRAP and you'll see, a Viewpoint it's called, and then part 3 has just come out, which is one on testing, and it's interesting. I've heard him on CNN or MSNBC or CBS the last couple of days. He talks about it in terms of smart testing, and so that's basically his approach to things. And he still says we're in the second inning of the 9-inning game. By the way, I kept trying to find out if we're in the bottom of the second inning, but wasn't able to tell me yet. He'll know in the next month or so. And that's basically it. And then from that end, and then it was interesting because he was very, very good last night when I heard some of his comments that you guys can look up, in the sense that there was a lot of CDC bashing. He just was the strongest advocate, got up there and just said just really good things about the people there and really stood up for them. And said that this issue about the the thing about the surfaces not containing as many bacteria or lasting as long, it was, I think most of us kind of already knew that to some extent. But still, we didn't want that to get lost in terms of, continuing to do hand washing and keeping things hygienic. It's just that people are not aware that there are other germs out there besides, the COVID virus. So he did a nice job of doing that, but we got to get the word out as well so that people understand that. I think it's been a good thing because it has gotten people in the right direction, I think, in terms of how we should, keep proper hygiene on a day-to-day basis. So good for him. Hopefully he can join us. We can thank him once again because he's been terrific. Then the next thing is, John Jew, speaking of which, I was going to have this whole talk about what I call inspiring remarks, but can you follow up a little bit on the conversation we had last week about this whole issue of the severity of illness and what you think leads to it? Because one of Mike's issues was that yes, you still can get it possibly from phone mites or from touching other objects other people have touched, but the main thing, it's not necessarily the coughing and sneezing, it's the air we breathe. So can you expound upon that a little bit more for me, if you don't mind, just so that everybody gets an idea of what our kind of position, I should, so to speak, should be, or at least that one of the knowledge bases that we should be retaining out there for our people.
Yeah, thanks, Paul. Can everybody hear me?
Yes, sir.
All right. So I just want to encapsulate the philosophy and probably the mechanism of acquisition of the COVID-19. I think as we learn more, and myself included, that we know that I would say the vast majority of the acquisition of COVID-19 is probably from airborne or droplets, primarily droplets with some airborne disease. And this explains the inadvertent acquisition of COVID-19 in churches where they're not touching each other as well. So if you actually focus on that, that's not to say the phone mites aren't important, but I think CDC yesterday actually changed their position and reemphasized the droplets and airborne disease. The second thing I can say is that we've learned a lot in the last 4 weeks about basic people talking or even coughing, and that droplets could be basically expelled up to 6 meters as well. So if you're in a room with bad ventilation.
Hey, let's emphasize that 6 meters is not 6 feet, right?
Yeah, right.
Or
6
like,
meters.
it's like 20
Yeah.
feet, okay? So
20 feet as well. And the droplets may hang around up to 8 to 10 minutes. So if you're walking in a room of a person talking, or worse than that, coughing, and there's no ventilation, and you don't have your PPE and mask on, you're at very high risk as well. The third thing I want to say without taking too much time is this is my personal belief that when you have acquisition, you could have, this is an inoculum effect. If you have a very mild inoculum, you don't breathe it in and it lands on your nasopharynx. And if you have a heavy inoculum and you're standing right by the patient's side, intubating the patient, you could be breathing in a significant inoculum. And that explains why some, if you look at the providers, ICU doctors, ER physicians, anesthesia, and even ophthalmologists, they are at highest risk here as well. So I think we learned more that, number one, to recapitulate, that droplets and airborne disease is probably the major way. Number two, that there seems to be the inoculum effect. And number three, that the airborne disease can travel up to 6 meters, translated 20 to 30 feet, and stay around for 5 to 10 minutes.
And John, as you and I have talked about in the past, is that it's sort of akin to radiation to some extent in terms of distance, time that you're there with the person, and also maybe the degree of what's there. So in other words, if a person is talking loud, that's why that we've heard about the choir singers, passing it on. If a person's in a bar, it's noisy and they're talking louder, and that's sort of the classic thing, and getting in each other's face. Those are very, very high risks, I think, from what everything we've talked about, correct?
Absolutely.
So, and so that's why I see inoculum, as you've always said, and that may correlate with the severity of the disease, correct?
Yes, that's correct. The other thing that CDC came out with in an internal document is that they estimated up to 30% of the individuals with COVID-19 are asymptomatic or pre-symptomatic, however you defined it to be.
Yeah. Okay. And then and by the way, if most of you don't know, but John actually is a PI for the CDC on emergency related infections up there in Pacific Northwest, and just really appreciate his expertise in keeping us up to date on all that stuff. So really, really do appreciate it. Okay, so next thing is Mike with Mike McAvoy. Just wanted to say that we'll keep on, or maybe next time I'll plan to do something specifically myself regarding this airway issue. Are you okay with next Tuesday?
Yeah, that's fine.
Okay, good. So I'm not sure. So which part are you in Tanzania, by the way? Just out of curiosity there. So
That was a good guess. Yeah, exactly.
Okay, good. All right. So
Hey, Paul, I'm online. I'm sorry I was late.
Okay, well, yeah, okay, David. Well, maybe then we'll start off a little bit on this with David Farsi. Just get in. Mike McBoyd, tell us what the charge was from the EMS committee at the International Association of Fire Chiefs.
So there's a lot of interest in airway issues in general, and then I think particular to this COVID situation, some of the concerns and what your thoughts are from the group about how we should be managing airways when that's necessary.
Yeah, and when we, and it maybe not just you're not talking about the airway, but actually just the respiratory support as well. In other words, and as I put it, oxygenation and ventilation as two separate issues, so to speak. And specifically, I think I probably wrote a note to some of the various folks that have contributed to our processes in the past, such as David Farsi and Scott Weingart, to try to join us, and Mike Sayer. And if they show up, that'll be good. And my specific thing was, and David, if you could address this, like, what are the triggers? So for example, let's say a COVID patient's being managed at home with a pulse ox. When do we transport? What's the trigger? So for example, if they're having increasing coughing and their SATs are less than 92%, when they were previously, say, 94, 96%, are they trending downward? And that's the time to do it. Is it anybody less than 92%, or is it less than 82%? If they're, or do you bring them in because they're having increasing dyspnea? Specifically, what would be the thing if you had your crews going out there? What would be the time that you want them to come and bring it to the hospital? What are those transport parameters? And does that change if we go to New York City? That'll be a second question, New York City situation. And then later, what I want to talk about, that's just the trigger I want to know. The second question is, if we do transport, do we simply start off with, like, say, 6 liters nasal, prongs, and then titrate to greater than 85%, or do we go right to a rebreather mask, or, so on? And when do we start CPAP? And then finally, if it's a cardiac arrest case, do we use an SGA, ETI? And that's where I wanted to have Mike Sayer. We could do this as sort of a part 2 later on, and then talk a little bit later when they're intubated. Let's do that later on. But David, if you can give us, what you would, as a person who runs the emergency department and also as an ICU doctor, when would you want the paramedics to bring somebody in, as opposed to managing them at home?
So thank you very much, Paul, and for everybody. Thank you.
If you guys don't know Dr. Farsi, he's the president of AAEM and also is the EMS medical director, let alone being a department chairman in emergency medicine at Sinai and Mount Sinai and Miami Beach, and also the an ICU doctor as well. So go ahead, David. I'm sorry to interrupt you.
This is actually a great question, and I think this is something that we've been looking at for the past 8 to 10 weeks now. I can tell you that our protocol when we discharge patient was less than 90, and we send them home with pulse ox, right?
Yep.
And at the initial, I had to reassess that extremely fast, because then suddenly our crews would say, wait a second, we have a patient now is 88, what do we do?
Yeah.
And I think across the state and across the country, in New York, Washington State, us, South Florida, kind of changed that and said, sending them home on 92 and with a pulse ox. Now, the problem with this is, do they have oxygen at home, and where do we tolerate? So if they have 92 and they're measuring it and their O2 sat doesn't drop, then it was fine. But if they drop below 90, then they're going to need to come back in. And so I think that what we've noticed with this disease is, even though if they're hypoxic, right, but they should be in a hospital setting, because we're going to have to manage for their anticoagulation issues, with all the issues that comes with COVID, and we're unable to predict which one are going to go into the cytokine storm. So I would use less than 92 as a mean to say they need to be transported to the hospital.
Yes.
Oxygen, I would start with nasal cannula, with a mask, right? And or if it requires more, maybe CPAP with a mask, and or or non-rebreather. This is going to be a judgment call. I would not target with a goal of maintaining O2 sat between above 92%, not trying to normalize the O2 sat.
Yeah. Okay. And so that's a great question. And so it sounds like all the things we talked about are there. One, I think, caveat I want to put into this is that the measurement is an important thing because we're making decisions based on some number. And we've talked about before, when we saw a 65%, we're not going to just jump in and intubate them because they don't respond to the oxygen treatments. We'll just bring them in and be careful about that, particularly if they're not in major respiratory distress. So that's number one. Number two, the number also could be wrong. I mean, I've gone into physicians' offices myself. They put a pulse ox on it, and it says it's 94. And so I just reposition it, and I'm at 98. And so part of it is to make sure that it's put on right, and that at different times, as you and I have talked about before, we'll have people test themselves by, standing up, sitting down, or whatever, and doing some exercise and see if they do drop it out. And so see if anything changes that, and make sure that their lungs are expanded as best we can. Because a lot of people will be maybe testing between 92 and 94%, depending on their position. But you want to look at the trend is actually more important for people who are at home, et cetera. And then the same thing, have our people double check this, maybe on different fingers or in different situations, and make sure that's positioned. So if we really are going to use pulse ox, then let's make sure we are thinking about all those things as well, right? So. Hey, David, let me ask you this then. The other issue that we've talked about in the past is avoiding intubation. What's your trigger there when you have them in the emergency department? Let's not talk about the out of hospital quite yet, or out of hospital. Let's just say what you're doing in the emergency department, okay?
So in the emergency department, if there's a supraglottic airway, we're going to use a supraglottic airway. We're not focusing much on the oxygenation, right, part. We're doing active CPR, and we're going to risk stratify the patient on potential good outcome versus potential negative outcome, and risk factors associated with COVID. I ran the COVID unit with we're collecting our data now at 157 patients. Severe, we had 42 of them were arrested. And out of the arrest, the one who went to VFib and VTAC were successful. We had return of spontaneous circulation in a significant amount of the number. And we led them with supraglottic airway and only intubated those patients with return of spontaneous circulation. I don't think that's surprising when we look at the data from other places. Hello?
Yeah, we can hear you.
We look from data from other places. Now, once we intubated, we were in a complete NOMAX. We had what's called a striker hood. We used the striker hood. I happen to have it in my office. It's the striker hood. It's the hood used by orthopedic surgeon with a helmet when they do joint surgeries, because it gives them like a complete sterile isolation. And we use a striker hood with a full suit, and it was no problem. Pre-hospitally, I think supraglottic airway is probably the best route, because direct visualized intubation should be avoided at all costs. And we only did gyroscope, video guided intubation.
Okay, got it. It's interesting. And I wish I had Mike Sayer on that they started out with supraglots for the reason you said, and eventually went back to intubation directly because that's what they were most used to. And I think the rationale for that was that they have a tiered system, so they have highly skilled paramedics, and that's what they were used to. So part of the issue was do what's going to be the easiest and what you're more used to. So that may be one interesting caveat along those lines. And then I'll have maybe people.
So my only issue with the direct, right? And it's not the question about skills.
Yes.
In a potential COVID patient, there's a New England Journal of Medicine article that just came out. If you look at the amount of a viral shedding or spread on the operator, right, who's doing the intubation, on the direct is extremely high.
Yeah.
Right.
Yeah. So let me now just turn a little bit to the positioning issue, which has been near and dear to you, in that we've said that you could try prone positioning, but maybe the even better thing is to try to do a kind of a rotisserie approach to see how they're doing on their side, see how they're doing on their back, how they're doing on prone, but the main thing is to try that. If let's say you have someone who's presenting with an 80% saturation, and it's confirmed it's definitely 80% no matter what way you look at it, you put them on some oxygen, and then you've found that you had good results when you did shift them around. The question is, what is kind of your general protocol, number one, and number two, what is your how long do you wait to see if it's made a difference? What's the usual, let's say, because it takes a while for oxygenation to change, right? So go ahead.
Yeah, I don't really want to discuss my data because we're in the publication phase right now. So I'll give you some hints. But all the patient, what I consider moderate to severe, aka the happy hypoxic, who is severely hypoxic, but alert oriented to place time in person, following command, we put them on a high flow oxygen, and then we taught them to do awake pronation, sit, turn to your right, turn to your left, and then prone if possible. If not, they were sitting, and we tried 12 hours out of a day. A recent paper from in JAMA from last week said that some patient only tolerated for 3 hours. In our group, all our patients tolerated for 3 to 5 days. The thing that's going to be challenged is, yes, you have increased oxygenation. Your O2 sat went up fairly rapidly. In our group, within 15 minutes, we went up above 92, and starting from 65 to 70s. In 15 minutes, we were above 92. Now, the problem is it's not sustained. It is not a sustain. It's not a recruitment, and you're fixing the VQ mismatch. It's absolutely not sustained. The moment the patient takes his O2 sat down or something, they go right back down. So it's, I think it's just a shifting of the VQ and allowing for oxygen.
Yeah.
Our group of patients, we had 77 patients in our group. 49 patients were excluded secondary to intubation immediately when they arrive into the ED. And our extubation rate out of the 32 patients was like 6%, with a 77% discharge home. Again, this is preliminary data. I need to have my we're in final production, final publication phase, and we're going through some pretty strict review criteria to make sure that we don't get hammered by the Harvard group who's telling us that we should have intubated all those patients.
Well, anyway, what I was going to say is that for the pre-hospital arena in general, this may not be something that we'll be able to determine a major difference right on the spot. However, if you have a longer transport or doing critical care transport, it's something you should think about that might work, that you might get some response within 10, 15 minutes. Okay. So, so that was it. So anyways, Mike, this is probably a good start. We may go into this a little bit more, but I hope this has been helpful to you right there. And so what I'm hearing is that we will try to treat a lot of these people at home, and then maybe 92%, if we've confirmed it's right, would be a nice trigger below there. And certainly if you're below 90, and obviously if they're having increased shortness of breath, cough alone may not be an indicator, but the other signs and symptoms would be something we'd be most concerned about. And then as we come in, we can try different positions. We try with the more conservative approaches to oxygenation and move your way up with all those things right up to CPAP if necessary. And then considerations, if you have to do intubation, one issue has become the pros and cons of SGA versus intubation. You've heard some of the points there. One of the reasons why probably they were able to do better in some cities is because they are doing rapid sequence induction with it. The other question comes up, if you're doing CPR, however, are you doing some spraying during that period of time, including gastric fluid? So it all has to be kind of played by ear, and having all those considerations are important. Anything else, David, you would add to that before, or anybody else in the group? Thank you.
Just Thank
Hey,
you
thanks,
very much.
Hey, and nice work on the paper you put out yesterday on coagulopathy. Really appreciate that. Okay.
No, thank you very much to you.
Okay.
Thank
Got
you
it.
very much for your
Yeah.
machine.
Good. No, it's a good team. So, hey, and thanks a lot. Hope your day goes well. Let's stay in touch this weekend. Okay.
All right, thank you very much. Good luck. Thank you very much for a great job, an outstanding job, and happy EMS week to all of you guys. You're really strong, EMS strong. So thank you very much for all you do.
Okay. Thank you. Okay, Mike. I hope that was a good start for you, Mike McAvoy. Right? And do you want anything else you want to pipe in on?
Yeah, no, I guess, one question that comes up frequently
Yes.
is when you have that patient that's quite happily hypoxic,
Yes.
so to say, how tolerable are you of that? And like, what are some indications when you'd say, okay, this person needs to be intubated, like someone who's really.
So that goes back to what I tried to bring up earlier, and that is, it looks like Mike Sayre just joined us, so I'll try to bring him into the discussion. So, so the first thing is that we don't treat the number. So first of all, make sure the number is correct. Make sure that you've tried it on either different figures or reposition it on a given patient at a given time. Because like I said, I could have it on my same finger and be 96% depending on how they put it on, and if I just adjust it a little bit more, all of a sudden I'm at 98%. So that's number one. But even if they're 68% and they're alert and oriented, they're not in a respiratory distress, don't chase the number is what we would say. I think we all say, let's go ahead and try to get some more oxygen on them. And and then you saw the progressions. He said, as long as they're not in any major respiratory failure or respiratory distress, you just sort of edge it up slowly but surely with the cannula, maybe then the rebreather mask, maybe onto CPAP. But by that time, we probably will be at the hospital in most cases. So this may be most applicable when you have long transports, though, and that's important to know. So does that answer your question there? Okay, and I want to try to turn it over to Mike Sayre briefly as a continuation of this, because as you heard, a lot of people would just go to SGA to minimize the amount of contact that the viewer has to do with looking at the airway or be exposed to it. But Mike, eventually you guys went back to endotracheal intubation. You were thinking the same thing. And I was wondering if you can give a counterpoint to what we heard just now, that to go right to SGA.
So I think Dr. Marino has raised the same issue, and that is that some of our physicians in the emergency department started to push back because their observation was there was probably as much or more aerosolization happening with the eye gels that our system uses, and we're maybe having some concerns that we were actually exposing our EMS crews to more aerosol by not doing intubation than and using a SGA instead. So of course, this is all conjecture, right? No one has any actual real data on this in terms of the relative risk of workforce acquiring infection. And I think our data that we presented on the NHTSA webinar a week or two ago showed that the actual risk of acquiring COVID-19 from caring for patients with proven COVID illness was actually quite low. And that's in a system that people have access to N95 masks. So the PPE works. I don't know that you actually really need to wear a striker hood and use a glide scope for this. Our teams are intubating these patients using direct laryngoscopy and an N95 mask, sometimes with a face shield. And fortunately, that all seems to work pretty well. So I think that's what we know to date. More to come as we get more data in our system, but I feel like the actual risk to the providers, assuming they're well trained in PPE and have N95 masks and face shields, I think the risk to the providers is low from doing endotracheal intubation.
And then the other caveat I did before you got on the phone was to talk about that. One advantage you guys have is that you have a tiered system approach, highly skilled people who do it all the time, and we're able to get a lot of cases under their belt at a very rapid period of time and develop expertise. And that was what they were most comfortable with. And that's
correct.
Part of that's part of it.
Absolutely. So we would not advocate that people change to doing intubation if they're not were doing that before. roughly half of our cases are drugs using RSI and half are cardiac arrest cases. So, there's a mix in here of what these cases are. The cardiac arrest cohort is, maybe out of the cardiac arrest cases that in our system, less than 10% of them have COVID disease. So, there's 90+% that don't have the disease. Now that probably was not true in New York City or New Jersey,
Right.
but I suspect in most of the communities, people that are represented on the phone here have incidence rates that were similar to Seattle. And that means that a minority of the cardiac arrest cases actually have the disease. So your mileage varies by your prevalence in your community.
So the key really ultimately is this issue of the PPE is number one. And number two is to keep in mind that, again, this is in the kind of settings you're talking about, and that things may change if you're in New York City setting, and that's something else to be kept in mind. Okay, anybody else want to weigh in on this? Mike Levy, for example, what do you guys think up there? Do you have any thoughts along those lines either? Or as well, I should say. See if I can catch Mike to get on. You may be unmuting.
Am I unmuted now, Paul?
Yeah, you're fine now. I hear you now.
We actually have sort of an eclectic approach with regard to airway and cardiac arrest. And so we do intubation. We are moving more towards VL than DL for intubation and cardiac arrest. But it all starts off with some type of non-ET tubes, so either bag valve mask or moving early to the supraglottic. But we really try to, we always look to our friends down south, all the way down in Seattle for guidance, because we're always very impressed by their data-driven approach. And the whole idea of PPE has been our main emphasis. So we're actually now moving to PAFR systems and stuff for our providers, as well as more durable coverings for them, just to enhance that.
It was interesting to see the striker hoods that they were using down in Miami. So that wonder if that would be another adjunct that would be of use. But it's the same issue whether you're using PAPR or whatever. It's really the protection end of things and doing what you're most comfortable with, so it's efficient and effective, et cetera, is what I'm kind of hearing as a sort of a general synopsis. If that helps you, Mike. Okay. All right, and then so Mike,
It's manifold.
please go ahead, Craig.
Yeah, just a couple of nuances that are out there in some other forums for EMS medical directors. And there's some reports of in the hospital setting with patient transfers of clamping the endotracheal care or taking the patient off the ventilator and things like that. So I think that for our folks, just for awareness that they may run into some scenarios where folks are doing that, and we often see what happens in the hospital, or folks try to emulate in the pre-hospital field. I don't know that that's necessarily a best practice, but the attempt or theory is to minimize some of the aerosolization that's out there. And with it, as we know, there's a lot of shortages with filters. So again, just something to be aware of. And then one of the other pieces is a high flow nasal cannula strategy to help manage some of these patients has been effective. Everybody thinks high flow nasal cannula is 10 liters of our classic nasal cannula we put on the patient, as opposed to some of the devices that are directly made for high flow nasal cannula administration of oxygen, like the Vapotherm. And those devices are great. They're not well used or well known in the pre-hospital environment because of their high oxygen utilization component with that, but it is some therapies in the hospital in the ICU. And the reason that came to mind is we had a patient at the facility I'm working at today that they tried to do an inter-facility transfer with, and the EMS crew was not familiar with the Vapotherm, and so the patient apparently ended up being intubated prior to transfer because of that. So just a couple of nuances that are out there and floating around in our.
Paul, can I add one thing to my statement?
Absolutely. And then I'm looking for anybody else who'd like to sort of, because I want to close this one out, but I want to make sure I got everybody's opinion if there's anything, major we need to hear about. So go ahead, Mike.
Well, I just wanted to emphasize, and I want to be very careful for people to understand my deference to all of my hospital-based colleagues. But when we bring somebody in who has suffered cardiac arrest and they're already intubated, it's a completely different setting these days than some way when we would bring in, even with an SGA in. The hospitals, at least in our area, are certainly very competent. But since we have a lot of concern, but pretty low incidence of COVID, the reaction at the hospitals becomes almost an overreaction. So things slow down there, at least anecdotally, while they get everything ready for, quote, the big intubation. If we bring somebody already intubated in from the field, it really actually kind of facilitates patient care by, focusing on that particular item that's more important than the airway at that moment even. So thanks.
Okay, great comment then. All right, anybody else want to pipe in on this thing before I move on to the next issue? Hearing none, I guess. Hey, Mike, I don't know if it's premature, but at one time I asked you about, because you have such a high rate of frequency of bystander CPR, so many people are trained there that usually have bystanders doing CPR. Did you guys look at that? I was curious to know, with everybody being at home, are you more apt to get CPR or you're less apt to get CPR? Are people not wanting to do it, or whatever the reason may be? Have you been able to look at the bystander CPR frequency, see if it's changed in your area?
Mike Levy or Michael Sayer?
Mike Sayer, yep.
Sorry, Paul, I was distracted. What was the question?
No, I was just asking. I gave a lead in about the bystander CPR thing, about why it might go up or why it might go down in this period. And I was wondering if you guys got the data yet.
We just finished this 2 days ago, and our rates of bystander CPR before and after our first diagnosed case, which was February 20th, first diagnosed death, which was about February 26th, is the same. So 57% of our cases are getting bystander CPR. Okay. And that includes cases in nursing homes, as well as in public settings and in residential settings that are not nursing homes.
Yeah, so I was interested in hearing that, because I didn't know, because you had people at home with you now more often maybe, or if you're alone at home, now and you weren't out in the public, where you might be more apt to get it. But most of the cases do occur at home, and so and you still have maybe someone calling in for you. So who knows? I mean, the point is that you didn't see any major differences, and that's kind of interesting in itself. Okay.
Yeah, and I think our telecommunicators deserve all the credit for that, right? Because they're the ones that are sort of pushing this agenda, and we did not tell anybody to put cloths over people's faces or masks on their faces. So we did not change our telephone CPR instructions in any way for these cases.
So what I'm going to do, Fiona, I'm going to be calling on you in a second or two. I just want to see if by any chance I still had Ricardo there. Ricardo, I don't want to take you by surprise. I don't want to also, I was glad to have you listen in. I didn't know if you had any comments. Rick's been one of us over the years and has been the director at NHTSA in the past, and has been just a remarkable person, especially in event medicine, et cetera. And so wanted to make sure he piped in and was hearing what we were up to, and just see if you had any perspectives from your end or anything to report to the the Eagles group. Hey, Rick Martinez, can you hear me? Okay.
Can you hear me?
Yeah, now I can. Okay, go ahead.
Okay, yeah. So no, I appreciate it. Paul had called me to ask me what was happening with various sports leagues, and that was one of the opportunities to share. And the long and short of it is, at the time that you called, I would say they were all over the board. They're kind of overly advised by infectious disease experts, but I think what the group like this has is operational expertise, and that's always a big gap between the science and how you operationalize it. Yeah. So what you're seeing, I think, more and more is the leagues are coming to the conclusion that they can open, and that they can open by bringing all the teams to one spot. So you're seeing competition between some various states. Major League Soccer is moving to Orlando, I believe, right? They've announced that. A few others have moved to that. And it's hard to have control of a easily spreadable or contagious disease with mass gatherings. So they're all focusing on not having fans in the field at this point right now. Now the big question is, what would be a testing protocol, and how do you test, and how often do you test, and do you test before they go, and then how often do you test when they go, and then what happens when someone has test positive? And all of that, I think, depends on a couple of things. One of them is the availability of testers, which all you know is challenging. And secondly is the accuracy of those tests. So I think most of those large organizations, at least as far as I know, and I know, Paul, you have your own insights, are struggling with going from here's a good idea and a good plan to operationalize. And I think part of that's being limited somewhat by the accuracy and availability of tests, but I expect all that to change in the next few weeks.
Yep. Okay. Well, I hope so. And then I don't know if you saw, you heard me mention earlier the CIDRAP report that came out on this and talked about doing smart testing, et cetera. But it may be a different issue of where you're talking about, because you have a group. We actually, it was interesting, we just finished doing a kind of a preliminary study with Meg Marino in New Orleans, and also the folks in South Florida. And we're able to interestingly identify that even if people who are PCR positive in the past, we checked them out later on. And what we found was that they, about 30% of the cases in both different cities, different test products, 30% were not positive. And as John, you and I have talked about in the past, it seems to correlate with the milder the symptoms, the younger you are, and perhaps the closer you are to when you turned positive or had your first symptom, these tests will be not show any antibody at all. So paradoxically, it's the younger people that didn't have, the positive the test. And so the antibody tests, it could be the tests themselves, but it also could be physiologically what's happening with this. But the most important thing is to follow the PCRs in your situation that you're talking about, correct?
Yeah, most people I'm talking to are prioritizing PCR for those exact same reasons.
Yeah. Okay. All right. Well, it'll be interesting. Let's stay in touch with this. I hope this is interesting so far for you. So, especially with your practice. So, really, hope we can be of helpful to you as well. All right. So, thank you so much. Let's see if we can move on then to another thing. Maybe it's time to bring on Fiona. See what's happening over the UK. Anything new happening? Anything starting to sprout up again, as we were worried about?
So we've seen admissions to hospital, ITU admissions, ITU occupation go right down. So right across the country. So in London, we're seeing very, very few new cases at the moment, and we've got much better ITU capacity. Just looking at the stuff down on my patch in Southeast Coast, we saw a spike in cardiac arrests. We saw the number of patients where resuscitation was attempted going down by about 15%. An increase in the number of DNAR orders that we were logging go up by 10% in early March. Bystander CPR dropped by 10%, it's now come back, it's at 52%. And we saw unwitnessed arrests go up. And I think that's because people were on their own. We've done a lot of PCR testing. We're now testing all residents of care homes. And that's probably going to become a regular occurrence. We're starting to roll out antibody testing, but there's a big caveat on that because we just don't know if being antibody positive equals having immunity. Right. So we're just gradually letting the lockdown go. It's being loosened a bit. You can go out a bit more. You can go to work if you have to. You don't have to stay at home, although you should stay at home if you can. That's the government's mantra at the moment. Schools are starting to open up on the 1st of June in a very limited way. Universities probably won't be going back to normal practice for a year. So all lectures online, things like that. So that's where we are, Paul.
Yeah, thanks for the update on it. So just listening to and talking to Mike yesterday and in our, like a week ago when Dr. Osterholm was on with us, he really is not expecting the let's say, the multiplication to take place for a few weeks, and we may be looking at the middle of June, end of June, even early into July, where these things start picking up again. And I'll tell you personally, the behaviors I'm seeing, because the signal being given is like, oh, it's all over now. It's almost like that's the mentality. Because I especially, particularly young people, saw yesterday, just talking to each other a few feet away, no masks on, and it's as if there's a perception that the virus is gone. And so I worried, because it looked like a bunch of young people with loaded weapons on as they were talking to each other and even drinking, and so that increases things. So we'll see what happens. That's all I can say at this point in time. All right, so let's move on through. Anybody else have anything else to add to that or questions for her before we move on to the next session? And next thing would be then Jim Augustine, if you don't mind piping in and giving us your usual report.
Unmute.
Yeah,
Happy end of the EMS week to everybody. Good to see you all. Most important, a couple of articles published. Paul, your group in South Florida did an excellent article in EMS World regarding the coagulation issues. Boy, that looked like an excellent article that otherwise would have been in Annals. But Hillary Gates was nice enough to publish it in EMS World.
Thanks, Jim. We already got 1,300 views of the article in like 4 days, Paul, so that's just going to keep going up.
Yeah, and I think that what's really nice is that we just got the information out right away to the crew that needed it. That's the main thing. So that's why I like the way we went, and so really helpful, working with you, Hillary. And thanks. It looks like it got like a high visibility as well. So I really appreciate that. So I think I got calls on it before it was even out. So it was really interesting, because we had put up I think a pilot thing, and it got got out there. So thank you so much for doing this. And by the way, it's excellent job to Mike Estreicher, and as we heard, David Farsi, and who've been on the line, and all the others that were if you look at the paper that contributed, it's a group of about a dozen of us that have been talking about this for about a month and a half, 2 months now. And what was really neat, and you've heard us present this here about a month ago, about using the TEG to actually determine what your coagulopathy is, or if you have, because could be hypocoagulation, or it could be hypercoagulation with low platelets. And so it's been a very useful, way of approaching things. And so maybe someday we'll bring that advance to the field. Okay, Jim, what else?
Anyway, excellent job. Joe Hawley also just published an important article about bystander CPR and our opportunity to continue to improve it. So Joe Hawley, great job.
Tell us about that. Can you, Joe? Can you tell us what you found?
This was an interesting study where we looked at disparities, racial disparities among bystander CPR here in Memphis. And this was actually a follow-up to a study done originally by Arthur Kellerman about 20 years ago. Yeah. And what we saw is that there's still some disparities, although we've closed the gap and we've overall raised the rate of bystander CPR pretty significantly.
Okay, got it. Yeah. All right. Well, that's really cool. And it's great to hear something that's non-COVID related, for once, which is terrific.
And a success story, Joe. Thank you.
Any other reports from your end, or either from you or Mike from the IAFC, International Association of Fire Chiefs or Firefighters? Anything else going on there?
Keep going. Cardiac arrest survey is out. Please put your data in. Okay. And it will be done in a very formal way to all the Eagles. Please, again, complete that survey. From the IAFC, IAFF, looking at second wave issues, and I think that's what we probably will be calling it. Optimizing our PPE, optimizing our use of testing, optimizing our use of vaccines. Be aware that there is going to be trouble in being able to track data this fall. As you know, ILI, influenza-like illness, has been used for many years so that even early in the evaluation of patients, whether in clinics, emergency departments, EMS, wherever the data source was, we could use influenza-like illness. there's going to have to be a new term used this year, particularly if we have coronavirus circulating at a high level. So you might want to look at your terminology that you have built, and I'm hoping that the ESO and other people will also take a look, and we'll be able to know that in the fall, in particular, if there's a number of things circulating, including RSV and influenza, et cetera, that we'll have to use something equating to infectious illness instead. And that will be important for you to be able to track locally what's going on in the infectious disease world. And then eventually for you to be able to fill in the blanks regarding whether this was influenza, RSV, pneumococcus, or coronavirus. So Paul, those are the big issues that are in front now. A lot of advocacy for getting PPE in the hands of public safety providers when we get to the fall.
So the other thing that it kind of rings up is this issue that if we had a vaccine and we wanted to use the firefighters and or other first responders to help us with giving vaccinations, one thought is to even start off with the influenza vaccination being part of it. So you get some experience with doing it. And I think there's maybe a higher demand. I hope there's a higher demand for influenza vaccination this year than we've had in the past, or maybe we go actively out into the neighborhoods to help elderly people or wherever it might be, or nursing homes. So just a thought to put in there as to put it on the radar screen as a possible approach that has a twofer there. Okay.
Good points. A question and a place for your advocacy now. Many states have allowed paramedics to do it. Some are now allowing advanced and EMT or intermediates, advanced or intermediates to do it. And the question is whether to bring it all the way down to the basic level. So you all may want to discuss this with your state EMS authorities.
Yeah, and then Mike Levy, in your position, both on the state medical directors, roster and at NASP, maybe start to weigh in on that one and help out, get that mentality going. So, all right. Let's see. Just I hadn't heard from Rob Holman last time, so I thought I might see what's happening in DC. So if you don't mind, Dr. Holman, going to chime in and see what's going on there on your end of the world.
You're unmuted.
There you are. You're off. Yep.
Okay. Can you hear me?
Yep. Yes.
So what we have been, the big news here is that our cases have really dropped over the last 10 days, 12 days. And the mayor released the Reopen DC plan, which is an interesting plan. It's kind of a patchwork of, I guess, little interest groups. And I guess for those of you who are doing those reopening plans, if you're having anything to do with that, I think I would just be focused on the sensibility of some of these. Ours is pretty good, but we're not ready to open really for, it looks like 6 or 9 months maybe. Gyms and pools are going to be closed till stage 3, which means only sporadic cases. However, massage parlors are going to be open in stage 2, which is earlier. Kind of strange.
There's a lot of stress. There's a lot of stress out there, apparently. Okay.
Yeah. One of the things that's really interesting, and I think this may be applicable if any of you were asked about this, they are in terms of church openings.
Yeah.
Rather than doing it based on density, and I know they're doing that in Detroit, for example, only 25% full, no contacts, isolating people, social distancing. Here, it's just based on a raw number. So it's 50 in maybe 3 months and 250 in 6 or 8 months, but it's not based on a density. So I think I would encourage you, those kinds of things need a little bit of medical input. So that's about it here.
Yeah, and Andy Garrett, since you're there in Washington as well, or at least nearby where you live, but you work there, anything else that you would add to that?
Hey, Paul. Hey, Dr. Holman.
Hey.
That's great news in DC. I think, my perspective is more focused at the university health level. I'm on the GW University Pandemic Task Force, and it's been fascinating to just think through all the different moving parts there. I had no idea. It's really a small universe to try and think about what needs to happen in terms of buildings and transportation and student belongings and all these types of things. So bottom line up front, we don't have an answer yet at GW, just like most of the educational systems around the United States. It's interesting to see how some, like California, have decided they're not doing it for fall, and some like Notre Dame have said, hey, we're doing it and we'll figure it out. So
yeah,
I suspect the answer is somewhere in between, but this is just kind of amusing. We've been put on standby to either start on time and then you go virtual, start virtual and then go on time, hybrid where you have some people in class, some people online, and every possible combination in there. But for those of you that run EMS education programs, this has been an extremely difficult time. We have hundreds of EMS students that we're trying to get through and not having the ability to get them on the ambulances and even do psychomotor type skills building and testing. It's been a real challenge, and it really caught a bunch of our graduating EMS minors and folks who are graduating with EMT certification in the lurch here, even though there's an EMT provisional certification. It's been a bit of a nightmare trying to figure out how we're going to get all those folks carded in the end, but we'll get through it.
If you can hang in there, I want to put it off for a couple of minutes, but they developed a really good plan in South Florida that I saw, or at least they're trying to be progressive about it. I think other people have done the same thing, but I'll put them on in a few minutes, maybe have Peter Antip report on that. But before we go to that, I did want to make sure that I think you may already, Rob, I think you already have good contacts at HHS. If not, Andy would be a really good conduit. So you guys ought to get together, even if the virtual beer or whatever. Okay. So
okay.
Have you guys met each other before? I didn't know if you have.
No.
We've met virtually. Yeah, I'll reach out again.
Okay.
It'd be nice. Thanks.
Okay.
That's fantastic.
Thank you.
All right, good. Hey, Erica Carney, tell me what's going on in Kansas City. We lost you last time because you had to get off the phone, but I want to catch up with you now.
Yeah, so we've had overall for coronavirus, our numbers still continue to be low. We have 0 personnel in quarantine right now, which for us, we had the 1 line of duty deaths. So that's been a huge focus. We are completely open though, and it's in line with your sentiments, Dr. Pepe, that everybody feels like they're untouchable at this time. So we're very interested to see what that'll look like in a couple of weeks from now. We've got county funding to do antibody testing for every single personnel in our county. So trying to procure those tests. I've been working with Dr. Antevi for that, but that's been a big focus of ours. On the bystander CPR, one of my biggest platforms when I transitioned into the full-time medical director position was increasing our bystander CPR for the UTSTEAM, specifically because VFib, BTAC were extremely low. Our county's predominantly Black or Hispanic, and low socioeconomic. So we saw a huge discrepancy in the survival rates in the bystander intervention. So we took our fire prevention zip codes for free smoke detector installations, and we overlaid them with our highest risk zip codes. And whenever we went into the houses of these high risk zip codes to install smoke detectors, we administered free hands-only CPR training. So we found a positive, a statistically significant change in our bystander intervention for CPR. And then Corona happened and we saw a huge increase, a 25% increase in our all-cause out-of-hospital cardiac arrest rates. So when we ran our numbers, what's interesting is our bystander intervention is still up. So we found that despite Corona, our patients in the poorest populations are still doing hands-only CPR. Compared to the national numbers, we're still usually about the same as the national numbers, or a little bit lower. So we're not as good as Seattle or those other agencies. But that was an interesting thing for me to see that because of our efforts pre-corona, we still have people willing to administer hands-only CPR in the midst of these increased out-of-hospital cardiac arrest numbers. The other huge increase we're having right now is penetrating trauma. Yeah. I don't know if that's because people are bored or what, but our traumas are about to blow last year's numbers out of the water. So we're going to continue to track that and see how that trend continues.
Yeah, the trauma guys have been watching this for the last month and a half, and they actually saw the number of guns and ammunition being purchased going higher. Yeah. And I think that also we see that the rate of alcohol purchase is going on. So you know what happens when you put alcohol with lead.
And our folks here love PCP. They love the uppers, and so everybody's always amped up and naked and shooting each other. So
amped up and naked. That's I could see that one. A lead story in EMS world or GEMS, right? So that kind of thing. Hey, so how about well, then that's really interesting. The other thing we have seen that we heard reported early on amongst our folks here, both from Berlin and to Madison, Wisconsin, was the amount of child abuse, domestic violence, et cetera. And I think that all goes along with this to some extent. So it'll be interesting to actually tabulate those numbers later on, maybe as a group, and put that together. So, okay, anything else then before I move on? Okay, hey, Joelle, are you there? Just want to check in on how you're doing, and especially since you're probably well along in your particular current state.
I am here. Good morning.
Yeah, go ahead.
San Diego. So I think our area that we're watching very closely is Tijuana. Mexico has been hit pretty hard for border crossings. The county that's next to us is Imperial County. They have 2 hospitals and are rather small. Actually, they transfer a lot of their higher acuity patients to UCSD, and they were hit by a large number of COVID patients, and did actually have the state and feds help out along with local regional response from our counties. So having a statewide integration plan was very helpful. And our South Bay, close to the border hospitals, are getting hit, but because we have an overall increased capacity throughout all of our healthcare systems, we're able to handle it. But it's something that we're watching very closely, especially as we're reopening step by step.
Okay, got it. And so how are you doing regarding reopening there? You okay? You're well along now, right? So when's your due date?
I'm due June 15th.
Wow, okay, cool.
Yeah,
so
officially it's okay if I go into labor because I'll be able to bring a child home safely, which is good.
That's what I was getting at. Nice.
Yeah.
Okay, good. So
Paul,
good.
AJ, can I have a minute?
Yeah, sure. Yeah.
I just want to let the group know, I did a deep dive. We have over 50 deaths now in EMS and fire. And I did a deep dive on EMS. And there's some interesting things. Obviously, New York, New Jersey has a high number of volunteer squads. So some of the data I'm going to talk about for just a second here, I'm going to go very fast. I looked at the 21 EMS personnel. And I looked at their obituaries. I did a deep dive where it did not give an obituary and found them on Facebook. And what I'm finding is that the deaths were over the ages of 50 for the most part. In some cases, the ones that were at the 50 level were unusual ones where the partner was sick but didn't die, and then the 51-year-old did die. But we have a lot here, and I'm just going to go through rather quickly. 69 years old, 6 great-grandchildren. A lot of people are leaving like FDNY, and then they spend 20 years with a private service. So the older EMS responders are the ones who are dying. Or, as I found when I did the deep dive on Facebook and other places, the ones that were young, including this Kevin, 24 years old, was significantly overweight. So overweight and elderly is a problem. Dr. Frank Marini, 70, a special events physician in Bergen County, New Jersey. He passed away. There's an awful lot in here that are 59, 63, 60, 63, 66, overweight at 49. So there's a subtle little message in there for services when we start to inoculate people. I don't think that people over 50, 60 should be doing inoculations. And then for services that are, have light duty, I think some of the people that are 60, 70, what happened in New Jersey is the squad simply went out of service and had to have somebody else cover for them. So age is definitely a problem. We lost a flight medic in Allentown, Pennsylvania yesterday from transfer of patients in the helicopter. So I don't know where that comes from. He was a very healthy 42-year-old ex-Marine. But there's a message about age and overweight, which we know is a problem.
Yeah, and then the other issue is again how you're if you are using a proper PPE under the circumstances that we're dealing with at the time.
And
so,
Paul,
yeah.
it's Hillary. AJ, anecdotally, I believe there's only one female. I think all deaths are male.
Yeah, and then the other thing I've been doing is calling around different departments and finding that the larger the department, the more the apathy about wearing masks and social isolating. They feel that when their state opens up, their fire station should open up. So we may see a flare up there as well because they're coming back from calls and they're You know, it's the typical post 911. It's over, so it's over. So we have to just encourage people to do proper PPE and decon when they come back.
Okay, listen, so as it's getting, thank you very much for that report. And since it's getting on a little late, I just want to move over to Miami because I hadn't heard from you guys for a while. Armando, you're there. Is Paul on by any chance, Armando? Or he's got his mayor meeting now, right?
Hey guys, how you doing? Paul's not here. How's everyone? Yeah, so we started opening up our phase 1 officially a few days ago. The county did, and then the city followed suit. Fortunately, we were able to have a couple of meetings, you know, Zoom meetings with some of the public officials a few days ago for the local municipalities. So everyone kind of got on board and did similar things, mainly like kind of restaurants, the marinas. The beaches are remain closed, of course, since we're kind of the worst, you know, hot zone in Florida. Although our numbers did decrease dramatically in the last couple of weeks. There was a spike a few days ago that we were very concerned about, but when we actually had the Department of Health on the line, because we had about 500 or so cases positive in one single day. And then it turned out—
In one single what?
In one single day. So like on the 18th of May. So it turned out when we got on with the Department of Public Health, it turned out that one particular lab had turned in a big batch of data that was lagging for a few weeks, actually. And they weren't able to separate out the dates that those patients were tested. Because those results were actually turned in manually. So the Department of Health has to go through those cases, each one, and go back and redate them. And I just don't know if anyone out there is having similar problems with data reporting as far as positive results from all these different labs. So it turned out that that was kind of an outlier, and we, you know, maintained a downward trend. And
yeah,
we, you know, we're still seeing some problems in some of the nursing homes, but not like before, since I guess, you know, most of those positive patients were moved into hospitals by state mandate.
I think that, you know, one of the things that's been a problem is that, one, the testing wasn't available or available to the public at large or certain populations, or you had to have certain criteria. And then as that it's expanded, then we're seeing more cases, but that may be an artifact from that point of view. However, but that's why I think places like, you know, I know, for example, here locally in Texas, we've looked at the number of hospitalizations that were related to it. And they have to keep up with that on a daily basis, and or deaths, but they always lag behind the case, you know, the cases, you know, when they by 3 or 4 weeks sometimes. So, so that's, but it does tell you just to be very wary of what data you're reporting out. The overall trends are the important thing, I think, as opposed to a day, right? Because that's what you're kind of getting at.
Yeah, and that's really all we can go by. Like we're still not seeing, you know, adequate death statistics from the medical examiners. So we're still not knowing what the causes of death are.
Yeah.
And that's a little bit concerning, because we did see, as we still do, increased DOA rate, but we just don't know if that's from COVID or, you know, are there, you know, common causes of death. I don't think we've seen a dramatic rise in suicides, as far as I know.
Okay.
But yeah, that, you know, what we have seen also is a decreased amount of testing, even though we've made testing available, you know, through the city as well as through the county, those drive-in testing sites, as well as our mobile testing that we have with our paramedics. The requests from the public have declined significantly.
Okay.
So they're actually seeing less. We actually closed one of our testing centers in the city because, you know, we just weren't getting enough appointments made. So I think the public's kind of, I guess, lost interest in a way, at least locally. I don't know, you know, if that applies everywhere, but there is, you know, access, but people just aren't using that. Maybe they're just afraid because they've heard of the discomfort from the test, or they're just not, you know, they feel like they don't need to get tested. So that's as well.
And that's probably what they've heard, because it's just like when people get their flu test, it's a lot of people have considered a brain biopsy. So that's been interesting. Just real quickly, if you got a 30-second response, Mike Sayer, for me, you guys were actually looking at your people who you pronounced dead on scene, and you were working with the medical examiner's office. Anything coming of that yet?
Excuse me, it's my COVID disease, Paul.
Yeah, exactly. Which one? The first one or the second one, right?
Yeah. Maybe it's the third time I've had it. I think we are having our paramedics swab noses on dead people in parts of the county, and I haven't seen a report. I just pinged our team yesterday to try to get an update on where that sits so we can get a sense of the compliance with this.
Yeah.
But it's presumably in their own self-interest to do this work
Right.
for us and to help ensure that we are actually capturing all the patients who die of COVID disease.
All right, got it. Well, I just wanted to, since you guys were on top of that, I wanted to see if you had any results yet. We'll see how that goes. Thanks. We'll keep looking pressed on that. Yes,
Paul,
Jim?
can I jump in? After Armando's report, I just came off the Georgia State call.
Yeah.
And you guys probably know Georgia has phased ahead a little bit of the other states. They are doing only 7-day averages in their reporting for counties or the state. Despite a few hotspots, which are poultry and pork and beef processing centers, and a few still congregate care facilities, all trending is down. And they look, most importantly, not at tests, as somebody pointed out, the number of tests is increasing. So case test positives will still go up, but most important, hospitalizations, ventilator use, and deaths are going down. So for those of you concerned about it, keep an eye on Georgia, which, as you know, is public health strong, been given good reports. Thanks.
Okay, good. Anything to add to that, Lakshmi, from Atlanta?
I'm sorry, I got distracted because of another call.
Oh, yeah. Just that Jim Augustine had just talked about the global findings in Georgia and how the number of, they're doing weekly averages and the number of cases seem to be going down. Jim, what else did you add to that? So I just wanted you to comment on it.
Yeah, no, I mean, I think that's about right. Our cases are not spiking up as of now. And the non-COVID cases are definitely creeping back up. So nothing more to add to that.
Okay, good. And it was just great for the report. Great also seeing your daughter the other day as well. So it was kind of fun.
Thank you.
Thank you. All right, so let's see how far we're doing here. 11:45. Yeah. So here in our neck of the woods. Ray Fowler, are you there? We haven't had a report from Dallas for a while. Are you there? I saw you on earlier before, but maybe not. So not there. Okay, and let's see. I'm trying to see if there's anybody else we hadn't talked to in the last week or two. Not that I see that's on. I did want to get a report. Maybe Peter, are you there? Peter Antebi, about the going back to this issue of the paramedic schools opening up and what you guys are doing about that down there. Are you on the phone still? Yeah. Yeah. Tell us what prompted that and what you came up with. You can give me like a 1-minute version on that.
Yeah, so we have several large schools here that we provide medical direction for. Paul, obviously, a big part of that. And we have hundreds of students. We have a big pipeline that allows our EMS entities to receive high-quality students. And when all this stopped with COVID, we were able to modify our online modules by kind of going to the online version. But the field and the clinical times, obviously, you can't kind of just make that up. We have a sim center that we're utilizing. But my goal is to try and get people back into the, back into ride times very quickly. And the only way to do that is to kind of go the medical legal way or the legalese way and have the students sign a waiver, number one. The second part is to have the agencies have the students sign a waiver to basically bring these kids back into the field without kind of creating this big backlog that Andy was talking about earlier. So this semester, where we normally have 90 kids sign up for EMT, we only had 9 sign up for EMT. And if you can only imagine what that's going to do as that moves forward through each semester, it's going to dry up the number of kids that we have to hire. And so I'm making a big push to try and get a policy and procedure in place. If anybody out there has already created this and you allow me to R&D it, I would love to do that. We're in the process of completing ours. So if you don't have one to share, we will surely share ours in the next week. So that's what I have to say about that. I think it's very important to get these kids back into
the field. Just one last comment, that in 2 agencies down here, we've only had 1 person get infected. So I think we've pretty much perfected, like Mike Sayer was saying, how to keep COVID away from our providers. The biggest fear is that our providers are worried about a student coming in and not practicing good habits. They're worried the students are going to come infect them. That's kind of the biggest fear we're hearing about now.
Interesting. Okay. Yeah. Well, I think that's part of the thing. So maybe part of the training is before people do go out there is to make sure they're properly trained, and maybe they'll be better than our current people to some extent if they're trained well, and then maybe create new habits for the future. I think because we shouldn't be doing this just for COVID. It should be for a lot of other things in the future, right? So.
Yeah, exactly. So our policy is not going to really mention COVID per se. I think that was your comment that you helped us out with, just to make it for the next pandemic too. So that's what we're aiming towards. Yep.
Well, then again, it may not be a problem if all our tax bases are going away and we can't hire people anymore. So, yeah, I hope it's not going to be that bad. All right. I'm just trying to look around the phone, see if there's anybody like Meg or Libby, Joe, any of the others want to pipe in and make any comments. David? Yeah, go ahead. Meg, anything from your end? What's happening in New Orleans?
We don't have any new updates. We're finally, I think, heading back into a little bit of a more normal state, or whatever our new normal is. We've been working hard to try to develop new processes to get things back to get things back up and running and really get ready for what could potentially be a second peak. So trying to find new processes to be more efficient the second time around, but things are going well. Thank you so much.
Okay, got it. So I just want to know if, if you could still get takeout from some of the restaurants at this point in time. So
yes, so they have even takeout from some of the fanciest restaurants in town.
Okay.
But yeah, no, the food is still alive in New Orleans.
Yeah. Okay, good. Well, we have some favorite, the Eagles have some favorite haunts down there. Want to make sure we get back to it someday. Yeah. All right. So David Miranantes, anything new from San Antonio?
Nope, we're opening up. Texas is opening up, so the bars are open. Yay!
Yeah.
So actually, with our gradual reopening, we are seeing an increase in rates. The hospital stuff's been pretty stable, and we're watching our hospital occupancy rates actually go up as we're doing elective surgery. So
okay,
we're opening up probably a little too fast, but so far we have capacity. So when Peter was talking about the students in the firehouse, so that is actually our biggest issue right now. Is we have locked down our firehouses so much now that kind of relaxing is becoming uncomfortable. They still have to social distance. They still have to use a mask. The poor probies are washing everything every 5 minutes, it seems like, in the firehouse. But even mixing of EMS and fire personnel, because they're on different shifts, is uncomfortable, which is kind of interesting. So now we're actually paranoid about other people in the house. But we are relaxing things slowly, and we'll see how that goes. But you're right, Peter. The ride-out thing is a big issue. Our pipeline is getting to be a problem, especially for the private ambulances. We are doing ride-outs with our own SAFD people, but they've been trained in PPE. They're under our jurisdiction. They understand the isolation problems. So that's different. But outside folks coming in, I mean, we won't even let the military ride right now, which is really weird, right? Because we usually have SAMC folks, our 68 Whiskey medics that are going to deploy, ride with us, but it's not been allowed yet.
Yeah. Paul, just so everyone knows, I added 2 files that we've created, a letter and a student disclaimer form. So I can start with that. And then when the policy is ready, I'll share it next week. But we are going to have to do some educating to the crews when the students come back in to kind of help them ease that pain that David's talking about.
Okay, got it. Thanks. I think the only person on the line that we hadn't talked to today so far, I think, is Libby Char. Anything new from your end? We had a good report from you last week.
Yeah, we're getting worried. Mayor opened churches as of this weekend, so that's going to be large congregate gatherings. They were worried about federal lawsuits in other states, so they felt like they had to open because they didn't want to have lawsuits filed.
Well, it would be good to sort of, that would be one way of doing the tracking of the people who got infected, because especially if you're singing and you're projecting more air out there and so on, depending on the service, I guess that could be more of an issue as well. So that's like the choir, that classic thing we heard about the choir people, all one person getting everybody else sick. So yeah, keep us apprised of what happens there. It'll be interesting in the next week or so. We may find out some new things. So we'll see how it goes.
Oh, I hope not. But yeah, they're trying to encourage the churches to not have singing and to try and space people out within the church. But I mean, you can only do so much.
Okay, got it. Hey, we heard from AG before. Hillary, anything new from your end that you like to pipe in about or talk to us about, Hillary Gates? If you're there still.
Yep, here. Yeah, sorry, yep. Paul. No, nothing here other than conferences and EMS. Any gatherings and stuff continue to look to be postponed or rescheduled or sometimes canceled or moved to online. So we're doing the same thing in terms of looking at what's best for EMS World Expo in September. And we should have an announcement within the next week and a half for everyone.
Okay. Okay, thank you very much. AJ, anything else to report from your end before I open it up to the group? Nope. Okay. Then anybody else on the line that want to pipe in and say anything else to add before I shut things down?
I'm sorry, Paul. I was adding.
Yeah.
I was on mute. There's an offer from a group called Wills for Heroes that by June 30th, that they apply, any medical responders, nurses, paramedics can get free will services from attorneys as a give back. So just Wills for Heroes, if anybody wants to pass that on.
Okay, good to know. There was, I forgot who mentioned this to me, and maybe it was Craig, but there was another service that was going on. Oh, I think there was a website where you could actually show pictures of heroes there. You could send in photos of EMS folks in action that might be, show what we're going through and why our first responders are heroes out there. So I can't remember who it was that told me about that, but there's something out there. I'll try to find out more information for the next time. And I said, well, it's already the end of the week, the MS week, but still, I think this thing is going to be going on. So I think that's nice to have that out there. Let's see, sorry about that. It's probably going to be one of those bogus calls, that kind of thing. Go ahead. What's your emergency? It's Robert with healthcare. Okay. Hey, yeah. So it was really funny because one time I had a patient in the hospital saying they were coming in for to get because they didn't have medical insurance and they wanted to come in and get plugged in with our hospital. We had a public hospital here, and just as I was getting ready to examine him, my phone went off and said, "Hey, are you in need of healthcare insurance?" And so I thought I'd just give him that phone number. But anyways, let's move on. And anything else, Joe, from you before we go? Or Craig?
No, we are good to go. I appreciate everybody's attendance and participation as always. And we'll look forward to talking with folks next week.
Okay, thanks a lot then. I appreciate it. And please give me anything you want to talk about or go over. Please contact me and let me know, email me or whatever to give me insights to make sure we're taking care of your needs. And with that, welcome back. Anything else? I heard something else. You're going to say something?
Yeah, Craig and Paul, are we going to have a call on Tuesday? It's the day after the holiday.
I think I'm going to plan to do it. And if we don't have a lot of attendance, okay, I just want to be there for the people who need us to be there. That's all that want to stay on the line with us. I don't have any particular major plans unless something comes up about any particular, and we can make it a shorter call as well. Okay.
Thanks.
So with that, welcome back, my friends, to the show that never ends next Tuesday. So we'll see you then. Thank you, everybody, for this. It was a good meeting.
Bye. Thanks.
All right.